Potassium-sparing diuretics have one signature feature. They prevent potassium excretion, which is unique, because all other diuretics stimulate potassium excretion. And the reason why they are able to save potassium molecules is their ability to inhibit aldosterone effect in the kidneys. They can block aldosterone effect directly as Spironolactone and Eplerenone, or they can inhibit the function of sodium channels which are stimulated by aldosterone. And to sodium channel inhibitors belong Amiloride and Triamterene. The major effect of potassium-sparing diuretics is to reduce sodium absorption in the collecting tubule. And as we said, they can do it by blocking of aldosterone effect directly, or they can do it by inhibition of sodium channels. And because potassium secretion is coupled to sodium absorption, these agents can save potassium molecules. So let's explain how they do it. So in the collecting tubule we have principal cells. Fluid that incomes to the collecting tubule has a lot of sodium molecules. And recall that because sodium is osmotically active, sodium attracts water. So water molecules are always accompany sodium molecules. In the collecting tubule we have sodium channels. The function of these channels is to provide reabsorption of sodium and water. And once sodium and water incomes into the cell, they undergo the second transportation. Sodium-potassium ATPase pumps out 3 sodium molecules. And as we know, water molecules moves together with sodium. So by this, sodium-potassium ATPase provides the income of sodium and water molecules into the blood. The activity of sodium channels and the activity of sodium-potassium ATPase is stimulated by mineralocorticoid receptor. And substance that activates mineralocorticoid receptor is aldosterone. So aldosterone stimulates both sodium channels and sodium-potassium ATPase. We have to know that transportation of 3 sodium molecules into the blood occurs simultaneously with transportation of 2 potassium molecules from the blood into the principal cell. And from the principal cell, potassium leaks through the potassium channels into the lumen of the collecting tubule. The activity of potassium channels regulated by the amount of positive ions in the lumen. Basically, positive ions as sodium inhibit leakage of potassium ions into the lumen. So in the first phase, collecting tubule reabsorbs 3 sodium and water molecules. So there is just 2 sodium and water molecules left. And 2 sodium molecules in the lumen cause moderate inhibition of potassium channels, which permits 2 potassium molecules to leak into the lumen. So when fluid leaves principal cells, there is 2 additional potassium molecules that will be excreted. Now 2 sodium and 2 water molecules and 2 potassium molecules income to the distal region. In the distal region, hydrogen transportation occurs. Hydrogen transporter provides transportation of hydrogen molecules from the blood into the cell and after through the hydrogen pump into the lumen. Hydrogen molecules make urine more acidic. The activity of hydrogen pump is regulated by the amount of positive ions in the lumen. And in this region, it's sodium and potassium. The higher the amount of positive ions in the lumen, the lower is the activity of hydrogen pump, so the lower is the transportation of hydrogen ions into the blood. And in this case, there are 4 positively charged ions in the distal region. So in the end, in normal condition, we excrete 2 water molecules. So in this case, it will be our normal diuresis. When we prescribe Amiloride or Triamterene, they block sodium channels. With blockage of sodium channels, sodium and water reabsorption becomes impossible. With decrease in amount of sodium ions in the principal cell, the activity of sodium-potassium ATPase decrease. Thereby, the income of sodium molecules into the blood decrease, and potentially this can cause hyponatremia. Because water moves together with sodium, the income of water into the blood decreases too. This will cause decrease in total volume of fluid in the general circulation, which will provide decrease in blood pressure, and also it will decrease the severity of edema. With decrease in activity of sodium-potassium ATPase, transportation of potassium from the blood into the principal cell decreases. As a result, the amount of potassium molecules in the blood will increase. Exactly this we call potassium-sparing effect, and potentially it can cause hyperkalemia. Hyperkalemia is the most common and the most dangerous side effect of potassium-sparing diuretics. We should be very careful with potassium-sparing diuretics in patients with renal disease and in patients who intake drugs that reduce or inhibit renin or angiotensin II activity. It's beta blockers, ACE inhibitors, and ARBs. Decrease in potassium transportation results in decrease in amount of potassium ions inside the principal cell. The second group of agents that we can prescribe are direct aldosterone inhibitors. It's Eplerenone and Spironolactone. These agents block the effect of aldosterone on mineralocorticoid receptor. If mineralocorticoid receptor remains in a passive state, the activity of both sodium channels and sodium-potassium ATPase will decrease, and eventually it will cause the same changes as Amiloride or Triamterene, so they have very similar effects. With decrease in amount of potassium ions inside the principal cell, the leakage of potassium ions through the potassium channels will decrease. In addition to this, as we see, the effect of potassium-sparing diuretics cause decrease in reabsorption of sodium and water molecules. So now there are 3 additional sodium and water molecules in the lumen of the collecting tubule. And now it's not just 2 sodium molecules, it's 5 positively charged sodium molecules in the lumen, and they will provide a stronger inhibition of potassium channels. So now there will be no potassium flux through the potassium channels. As a result, there will be no potassium ions in the lumen of the collecting tubule. So fluid that incomes to the distal region do not have potassium molecules, but instead fluid has 5 sodium molecules, which give us 5 positively charged ions in the lumen. With increase in amount of positively charged ions in the lumen, the activity of hydrogen transporter decreases. As a result, less hydrogen ions will be excreted into the lumen, and thereby more hydrogen ions will remain in the blood. And accumulation of hydrogen ions in the blood with time will cause metabolic acidosis. Metabolic acidosis caused by potassium-sparing diuretics is similar to type 4 renal tubular acidosis. In the end, instead of 2 water molecules, with potassium-sparing diuretics we will excrete 5 water molecules, and we call this effect increase in diuresis. But aldosterone inhibitors have one very specific side effect. The problem is that spironolactone can block not only mineralocorticoid receptor, but also it can block androgenic receptor, and blockage of androgenic receptor potentially can cause gynecomastia. Interesting that Eplerenone do not cause gynecomastia, and we assume that it's because it's a more selective agent. Also, Triamterene in combination with indomethacin in some cases can cause acute renal failure, and we know that Triamterene can precipitate in the urine, and because of this, sometimes it can cause kidney stones. So, based on toxicity, we know that potassium-sparing diuretics are not the best choice in patients with chronic renal disease and in patients that have hyperkalemia. In addition to this, drugs as erythromycin or even grapefruit juice can markedly increase the level of eplerenone in the blood because they inhibit cytochrome P3A4. The most common scenarios where we prescribe potassium-sparing diuretics is aldosteronism, both primary and secondary. Also, we know that eplerenone can block fibrotic effect of aldosterone, and it's the reason why we prescribe eplerenone for patients with diabetic nephropathy and for patients after myocardial infarction. Also, we have to know that Liddle syndrome is treated with Amiloride, and on the right we can see the dosage of drugs.